did that hysteresis loop thing, yeah?
Oh, yeah.
Yeah, so you remember the hysteresis loop.
Yes.
So when you take the lungs out of the chest and make the volumes bigger, the pressures that you require to do it at various parts of the cycle are greater or lesser, and you've always got more volume. So this is volume, yeah, and this is pressure on the expiratory side and the inspiratory side. So the way to think about that is like blowing up a balloon. So when you start off blowing up a balloon, you go red, so the pressure goes up, but the volume doesn't change, and then all of a sudden it goes, and it becomes much easier. So you get a steep rise, so you get much more volume change for less pressure. And then at the top, you've gone red, everyone's going, because the balloon's really tight, yeah? So, and that's up here, where you've got what's called the upper inflection point. And then, when you let the balloon down, the volume is bigger for the same pressure all the way down. Okay? So that's what we're doing. So that's, if you like, is the basis for any sort of recruitment and any sort of lung protective ventilating strategy. So if you consider what the alveoli may look like, at the beginning, you've got something that's a bit collapsed, flat, possibly no gas going in at all. Then you've got one that's a bit sort of raggedy, so poorly ventilated. Then you've got your normal one. And then if you're not careful, you're going to end up with something that's over-distended and liable to burst or fracture. Okay? The recruitment, so when you're doing this, you're going from here all the way across to here. But you do not want to be ventilating back and forth like that, because then you just cyclical lung injury. So what you want to do is you want to get to a point where, as best you can, you're probably ventilating there, or even if you were in there, but you're not going to be able to do that. And then there will be some lung that isn't recruitable. You can't get it open. So the more pressure you use, you're just going to damage the rest of it. So you don't want to be even trying that. Now, if you think of a frequency distribution, I should say number really, but essentially, as you're going along here, if you think of the number of alveoli that are opening for any given change in pressure, essentially at the bottom, nothing much is opening. The pressure's going up, but nothing's opening. And then all of a sudden, lots and lots of them start to open, and then as you get to this top point, less and less of them start to open, because they're all open. Yeah? Mm-hmm. On the way back, nothing closes, then it starts to close, and then they all start to close, and then when you get down to the bottom again, they're all closed. So if you go around that hysteresis loop, you could get to a point in the middle somewhere where if you didn't let it go back below that point, you've got most of the lung open, or as much of the lung open as you can get open. So that would be where your peak level ought to be set. That would be what you would maybe consider your best peak. Mm-hmm. Yeah. Now there is doubt about what that may or may not be in this subset of patients, but in general, if you're talking about an odds type ventilatory strategy, you're probably thinking that best peak is going to be 15 to 22, something like that. Now, it may not be as high as that, but that is not a bad place to start. If you start on 5 or 8, that isn't going to cut it. So somewhere like that is probably where you want to be to start with. So that's PEEP. Tidal volume? VT, I should say. How much roughly? Any ideas?
4 to 6 per kilo.
Yeah, so 6. You may need to go to 8. The lungs are compliant in this. Mm-hmm. Weirdly, they are relatively compliant. So you may not need much of a driving pressure to get 6 mils per kilo. So 6. Some people go to 8. Some people stay at 4. If you can get it lower and you can still get decent gas exchange, take 4. Okay, so tidal volume is 6.
Sort of lean body weight. Or do you use actual?
Yeah, it's sort of ideal.
Yeah,
Right.
yeah.
Yeah.
Ideal.
Yeah. You may, it can be difficult. So we've said so a Pmax. Now Pmax is a bit tricky. These ventilators are not good for the sort of respiratory mechanics measuring that the other ones are. So you're just going to have to go for Pmax. Pmax is actually P plateau. That's what you want to be thinking of, because it's the P plateau that the alveolus sees, and it's the alveolus that you're worried about damaging. So if you think of someone who's got asthma, for example, you may have a shockingly high Pmax because you've got to get through the airways resistance, yeah. But the alveolus may not see all of that Pmax. Now you can't test that on these,
Yeah.
so you're just going to have to play it by ear by looking at your end tidal CO2. What's that looking like? Is it a nice castellated one, or is it slowly rising? Or having a listen. Are they super wheezy? Yeah. So if you're super wheezy, then your P max is going to be above your P plateau, but your P plateau is the important bit
It's
for
most
alveolus.
important.
So if they haven't got any wheeze and you've got a nice castellated looking end tidal CO2 trace, the P max and the P plateau are probably largely the same, and you want to be around 30 as a maximum. Yeah. So there are certain things that you've got to avoid going over. So you're trying to avoid going over tidal volume of 6. You're trying to avoid going over P max of 30. Okay.
And plateau is
Plateau is the same
It's the
because
same.
you can't measure P max and plateau separately on
Okay.
these ventilators very easily.
but on your ventilators we can.
On our ventilators can, but we're not letting you have those.
Oh, I know.
IE ratio. So it's usually 1 to 2. That's a kind of bog standard setup. We all do that in theatre, don't we? So whenever I start someone on a ventilator, I always think, what is the problem here? Is it gas in, gas out, or both? Now with most of these patients, it's going to be gas in, yeah, because their lungs will be somewhat stiff. Now they're not as stiff as we thought, but they are still somewhat stiff. They don't have airways obstruction, because they've got airways obstruction, COPD, asthma, then it's gas out, yeah, and then you need to lengthen up the E time. So IE ratio, where are you going to kick off? I would probably kick off at 1 to 1. Okay, and so it's kind of ballpark where we'd start from. So 1 to 1 IE ratio. If you invert the IE ratio, you're spending longer in inspiration. So instead of going, you're going, and the more you do that, the more you get close to APRV. The difficulty with these ventilators is that they will go 1 to 8, but the most you can invert the IE ratio is 2 to 1. You can't go beyond 2 to 1. So they aren't very good for inverse ratio ventilation. The other thing to say is ventilation mode. Got to be pressure control. If you try and set it up in SIMV mode, it won't allow you to set the IE ratio. It will only allow you to set the I time, and then you'll have to calculate the IE ratio. So always pressure control. So initial setup, for the hell of it, 30, PEEP, 15, rate. You don't need a fast rate, so somewhere between 14 and 18 on the rate, and an IE, I'd set the IE to 1 to 1.
The P inspired, isn't that the on top of the P?
Sorry, that is, you're right.
Yes, it's gonna be, yeah. 15.
Beg pardon, 15. Yeah.
15.
Yeah, so that's, now, the difficulty with that, of course, is the mean airway pressure. If you do that, the mean airway pressure will be relatively high. So you may have concerns about squeezing the mediastinum by doing that. And you may find that they get a bit wibbly in terms of blood pressure.
Mm-hmm.
Anaesthetists and most people's sort of knee-jerk reaction to that is either give a ninotrope or give 500 mils of Hartmann's. You probably don't want to do that. And you're going to end up, if you're putting them on, you're going to end up being perhaps a little bit braver than you would normally want to be. But tolerate a bit of hypotension, it'll probably recover. If it doesn't recover and your oxidation's all right, then just tweak down the peak.
Mm-hmm.
Yeah, so put it down to 10 or something and see if you can go again. And you can often build it up rather than go the whole hog all at once. Okay.
So I can understand why you might want to avoid fluids, avoid the inotropes, just because.
No, I don't. You can give a wee bolus or something.
Yeah,
That'd be
yeah.
fine. Don't rush into starting
Yeah.
them on NORAD.
Okay.
What we find is, because it's quite difficult often if you start something. I mean, they may need it because you're going to sedate them as well.
Yeah.
But just be slightly careful about going, oh, I'll put them on the vent, it's all gone a bit horrible, I'll bang in some NORAD and I'll get them on this and I'll get them on that, because you escalate your workload quite quickly if you do that.
So the SIRS sort of sepsis component is not as significant when by the time you're choosing them.
So,
For them.
no, I don't think so. If they've got multi-organ failure in SIRS, then the outcomes for that with COVID are terrible, absolutely awful. So if we're looking at the right-hand side of my chest, and that's my trachea, yeah, and this is my right lung, and those are my vertebral bodies. What we, and you've seen the x-rays as well as I have, is that there's a lot of sort of peripheral consolidation stuff all over the place, but often quite low down in the chest. Now, I don't know why that is, but I think, and I'm it's a fairly science-free zone this, but and some of this is my personal opinion, and you feel free to take it or not. But I think there's an issue with this that we make worse when they first come into hospital. So you've got someone at home, and they're doing whatever they're doing. The other day I was saying George Matthew here, but that's not a nice thing to say at all. So anybody would be at home, stood up, or sitting up, or whatever it is, and that's where they are, okay? And you can think about what their lung mechanics are doing when they're like that. They get worse and worse, they spend more time recumbent, and they don't breathe as well. Yeah, and I don't know that that's why it ends up where it does, but it may be. They come into hospital, and what do? Well, we do that with them, don't we? So we lie them down flat, and of course, if they do happen to be of a certain body habitus, then that happens. So you get a lot of pressure, and they get a lot of, tend to get a certain amount of atelectasis basally. And then what we do is we tend to give them a high inspired oxygen fraction, or we give them a relatively low inspired oxygen fraction, and you aim for a SATs of 98. And they're doing this I'm sure they're doing this in A&E and on the wards all the time. And the patients are a bit rubbish, and they're a bit sort of like groggy and whatever, and then what happens is they don't breathe brilliantly well, but you've got a high inspired oxygen fraction. So you're just getting loads and loads of absorption atelectasis. And so by the time you get to see them, they are deeply hypoxic, because as well as their ARDS, they've got a load of absorption atelectasis on the top. And I think that you've probably got to try and deal with that in your initial ventilator settings, and then go on from there to kind of continue to manage them. So, now I nearly always, when I put a patient on a ventilator, do a recruitment manoeuvre. Now you don't have to do that, and I don't think at all it's mandatory, and I think if you use a nice short IU ratio with a high level of PEEP, as we've said, then the gas exchange will improve, and they will recruit gently. But if you're in extremis, you may want to consider doing a recruitment manoeuvre, because the other thing is, if you recruit them slowly when you could have done it fast, then you're going to be exposing them to a high inspired oxygen fraction for longer, and again you want to avoid that. So 2 ways to do a recruitment manoeuvre. Now interestingly, I hadn't realised this, but on these vents, if I stop this in expiration, I'm going to turn the flows up. I always start them on 100% if they're a bit unstable as well, because you can always rack it down. So lots of this. Now, if I turn the APL valve down, I can turn the APL valve down to anything I like. Yeah. So let's say I've turned the APL down to, I think that's 50, and let's say it's 40. So I could just flip them off the vent in expiration, and then we've got 40 for 40 straight away, and I haven't had to disconnect them. I haven't had to do any sort of holding on the bag. I hate bagging, personal thing, and I know other people don't, but I really don't like bagging. So fill the bag up, get it all nice and tight, and then you flip them from one to the other, and then you've done 40 for 40, which is a basic recruitment manoeuvre, and then back you go, you're back on the vent again. So that may be quite a useful way for you. We can't do that on our vents, but you can do that on this vent. So there's 2 RMs, recruitment manoeuvres. So there's the 40 for 40, yeah. And if it's someone really big and they're really hypoxic, you might want to do 50 for 40. Yeah.
50
centimetres of water.
Yeah. Okay.
For 40 seconds.
40 seconds, yeah.
For 40 seconds.
Yeah.
Okay, so it's
Yeah.
pressure and it's
Pressure and
seconds.
40 seconds.
Okay.
Yeah. And then the other way of doing a recruitment manoeuvre is the ramp manoeuvre. So you've got, say, 15 over 30. We've got 25 over 10 here, but that'll do. So let's say you've got 25 over 10. So that's what we're running at. So
So 25 is the peak.
So
and the
25
10
is the
Plus
is the is the
inspiration
is the P max.
Okay.
Mhm.
10 is the PEEP.
Yep.
Yep. And you're on a 1-to-1 IE ratio.
Mhm.
So if I'm doing a ramped recruitment manoeuvre, I put them on 100% oxygen, leave them on a 1-to-1 IE ratio, and just push the low PEEP quite near the high PEEP. So you've then got a driving pressure which is, oops, sorry, that's the PEEP, and that's the driving pressure. We're probably going to change to 25. So I would go to say 25, possibly even over 20, 25 over 15, something like that. And then I just take the whole thing up and up and up. So you shorten the driving pressure, and then you just go up, up, up to as far as you dare go.
Maximum.
So what you're increasing?
I'll show you.
Okay.
Is there any risk of
So I'm going. So here we've got 25,
Yeah.
yeah, as the peak
Yeah.
pressure,
Yeah.
10 as the PEEP.
Yes.
Yeah. So I'm going to actually drop this. That's going to. Oops, sorry. That's going to 10
Yeah.
over 10.
Yes.
But actually, I'm going to put that up to 15.
Okay.
So now what I've done is I've dropped my driving pressure to
Yes,
10,
to 10. Okay.
and now I'm just going to serially ramp the PEEP,
Yes. Okay.
which will ramp the peak airway pressure.
Okay.
Yeah?
Mhm. Yeah. 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 Yeah.
So I'm just keeping going to do that.
Yes.
It's going to
okay.
alarm in a moment.
How long are you leaving it in between each?
2 or 3 breaths.
Okay.
Yeah, and I'm just going to keep going
Yeah. Mhm.
until I lose my bottle. Now, that will be.
when do you lose your bottle?
When you have
I usually lose it at around a P max of 55 for a big fella.
Yeah, but for a small.
P max of
But
55.
but you've got to play it by ear. You cannot be doing P max of 55 on everybody.
Yeah.
And that tends to be why I don't use a 40 for 40. But I'm not saying you shouldn't. I think a 40 for 40 is perfectly reasonable for 90% of the population. You might want to think very carefully about their underlying lung disease if you're going to do this. So if they are raggedy COPDs, I don't think you're going to be seeing a lot of those. But if they are, you may not want to do this. So do that. Get to the top. By the time you've got to the top, the blood pressure's starting to fail.
Mhm.
Because you're squeezing the mediastinum quite hard. Again, be brave. Don't give anything because you're going to let it all off in a minute. So don't be brave. Tolerate the blood pressure dropping for a short period of time. So 30 seconds a minute. Tolerate the SATs dropping as well, because what you're going to be doing initially is you're going to be over distending all the open lung units. So what you'll do is you'll over distend all the open lung units. You'll squeeze those alveolar capillaries, and so the oxygenated blood through the heart will drop. So the SATs will often drop at the start, and then they pick up a bit later as you pop open some of these ones at the top end of your hysteresis loop. Okay, so if it all goes terrible, then obviously you just rack it straight back, but you haven't lost anything because the blood pressure will bounce back. So that's what I do. So 40 or 50, 55 in exceptional circumstances for a recruitment manoeuvre. Do it once, and then what you do is you just go back on the peak. So you just go down, you're running 100% oxygen. If you want to do a gas, a gas would be extremely sensitive, because a gas, as soon as you start shunting more, your PaO2, which might be 45, will drop. But you can't do a blood gas every 2 minutes when you're doing it, or every 2 breaths when you're doing this, because otherwise you've got COVID patients and blood and.
Is there only one blood gas machine we're using?
Yeah. So what I do is I drop the PEEP in 3s. Just keep coming down. With every 1 or 2 breaths, because you've got to see what happens to the, and until you get to the point where you go from 21 down to 18, and the SATs drop off. As soon as the SATs and it start to fall, because you're running quite a high inspired oxygen fraction, so by that time you've already lost from 45 down to whatever. So it may be, because remarkably, if you recruit someone with recruitable lung on 100% oxygen, you can get PO2s of 40. So they will have already started to drift down to 15 by the time that's, or 14 or whatever, by the time the SAT starts to fall. So by the time the SATs start to fall, as soon as they start to fall, you go back to and you sit, and that's your best peak.
And what sats should we be aiming for? Sats of
So-
98 or
No,
92?
absolutely not.
Yeah.
So once you've got that, you now think you're right. We're at best peak. We think the lung is best recruited. So now what we do is we
Decrease the
absolutely wind down the FiO2. Do it like crazy. So an FiO2 less than 60 is absolutely mandatory, I think. And the reason I say that is because you're getting superoxide radicals. Everything over 21 is rusting you. So if you expose them to FiO2s of 60, 70, 80 for 12 hours, they've got a pneumonitis. So you've got to get the FiO2 down. So if you have to, keep these up to get that down, I would do that.
Okay.
So keep the PEEP and the PEEP max plateau pressure up in order to keep the FiO2 down.
So with what you say is like best peak or optimal peak.
Yeah.
Does compliance give you a clue or not?
No,
You
that's
can't.
the well.
Yeah.
In general, it does. So if you've got somebody, what tends to happen in ARDS, if you imagine someone's got pancreatitis, if it's a great big fellow with pancreatitis, their lungs are really non-compliant, and you're going to need a lot of PEEP. PEEP, when you've done a recruitment manoeuvre, is about holding what you've achieved. If you just put 5 of PEEP on and don't do the recruitment manoeuvre, you haven't been around the hysteresis loop, so nothing's ever got opened. So what you're really doing is you're applying that PEEP to the open alveoli. So as far as you can, you've got to try and get something open. So I would always do a recruitment manoeuvre if you felt the patient could tolerate it. If you don't think they're going to tolerate it, or if you start and they don't tolerate it, okay, back off, do the best you can with the pressure control, and they will probably recruit a little bit slowly anyway.
What were you doing with the PMAX when you were coming down on the PEEP index?
So leave it the same, because you're just looking at that tidal volume of 6. Because you see the Pmax is always above the PEEP. So you're on the way down, the Pmax is above the PEEP. So the Pmax is not holding, it's doing the ventilation, but it's not holding the lung open. So the recruitment manoeuvre is all about getting the lung open, and then you start fiddling with the Pmax in order to get your tidal volume and your CO2 clearance for later on. So you may use a small driving pressure above a high PEEP, which you then have to turn up a bit in order to get the tidal volume that you were looking for.
Okay, thanks.
Okay, so tolerate. Okay, so obviously we're doing permissive hypercapnia ventilation here. So it doesn't matter. It does not matter. Now, normally I say, and anyone who's ever been on an ITU ward round with me will know that I say greater than 7.25, and then I always adjust it down if I can't achieve it. So I might as well start with I can't achieve it. So 7.2, and we're all talking about 7.15 now. PO2 normal. We normally say greater than 8. We're going to be tolerating, I think, if the way this is going, I think we're going to be tolerating less, but definitely 8. If you're setting it up and you get 8, you're laughing. And if your FiO2 is greater than 60, you're going to be turning that down until you get to 60. And if it means that the PO2 goes to 8, so be it. So that's all we're looking for. Yeah. The only other thing you're looking for on the gas, that I know this is a long way down the track in terms of, is my oxygenation adequate? I mean, this is not, it's obviously not a direct. It's not a direct link between the oxygen and the metabolic state. But if your metabolic state is good and your gases are shit, it doesn't matter. Most of these patients will also have, don't forget, they will also have a central venous catheter in. Hopefully it'll be in the neck. So you could measure a central venous catheter oxygenation just to see what they're extracting. That might be useful. Do bear in mind that you'll have more than 3/4 asleep, so their brains won't be doing very much, so the SVO2 may be quite high. So don't worry if the SVO2 is high, only worry if the SVO2 is low.